Okay, it looks like we've got most of our attendees into the Zoom room now, so we'll go ahead and start. Welcome to today's webinar on sexual/affectional identity. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, housed at Rutgers School of Health Professions, Department of Psychiatric Rehabilitation and Counseling Professions. My name's Ann Murphy, and I'm the director of the center, and I'll be helping to facilitate the webinar today. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health and other related workforces to deliver evidence-based and empirically supported practices to individuals with mental illnesses. I encourage you to visit the MHTTC network website, where you can then go to our specific site for the Northeast and Caribbean at mhttcnetwork.org. We also have a email distribution list. So if you're interested in keeping up with our latest activities, our webinars, our resources, eventually when things get back to normal, our in-person activities, you can go to the bit.ly link that's indicated here to sign up to receive our notifications. That link will also be included in the chat box here in just a minute or so. We also wanted to ask that you complete the survey that you're going to receive via email following this webinar. We'll also post a link to it in the chat box at the end of the webinar, but you'll receive the link directly to you in an email. We really value the feedback that we get from you. We're also required to do this through our funder, and having that feedback is part of what allows the funder to know that people are utilizing our services. And it also allows us to improve the activities that we have so that they're best meeting your needs. We also wanted to let you know that the webinar today is being recorded and will be posted to our website in the next couple of days. Lastly, we wanted to let you know that the webinar today will be interactive. We're interested in hearing from you and hearing what you have to say. On your screen, there's an option for a Q&A. You can enter questions there. Those will go directly to me as the facilitator and my colleague Kati, who's also going to be managing questions and comments that come in. Or you can post in the chat box as we go throughout. So Anthony, our presenter, may be asking questions of you, in which he'll ask you to put answers in the chat box, or you can simply comment or ask questions. Any questions you indicate in the chat, we'll gather those throughout the webinar and present them to Dr. Zazarino during the Q&A period. I did also just want to mention that if you're making a comment in the chat, you can change who's able to see the chat. So I think it defaults to only letting the panelists see what you type, but if you want to post something so that your other webinar attendees can see that as well, just make sure you click the drop-down arrow next to the 2, and you can select to have all participants, all attendees, see what you've typed in. Okay, with that housekeeping out of the way, I'll go ahead and introduce our presenter. Dr. Zazarino is here with us today. He's an assistant professor at Rutgers University in the Department of Psychiatric Rehabilitation and Counseling Professions, where he's currently a core faculty member in the master's program in rehabilitation counseling and the doctoral program in psychiatric rehabilitation. He's also a field experience coordinator for the counselor education and supervision track of the PhD program. Previously, Dr. Zazarino has provided instruction for professional education courses for the New Jersey Supported Housing Agencies, implementing community support services. He actively presents at local, state, national, and international conferences related to sexual and gender minorities, multiculturalism, psychiatric rehabilitation methods, counseling services, housing, and supervision practices. In addition to his work at Rutgers University, Dr. Zazarino continues to conduct clinical work by facilitating group therapy for adolescents and adults at an intensive outpatient program, providing outpatient counseling services at his private practice, and providing clinical supervision for counselors who need supervised clinical hours in New Jersey. We are very happy that Dr. Zazarino is able to be with us for this, the second webinar in his series, and I will turn it over to Dr. Zazarino at this time.
Thank you, Dr. Murphy, and thank you everyone who is taking an hour out of your day to join us. I feel really honored. I'm looking at the number of participants, and I feel really honored that you all have decided to take an hour out of your day in the midst of everything that's going on to be here and learn a little bit more about this topic. What I will ask is, since we are here and we're here together for the next 53 minutes, is that we try to stay as grounded and present in this moment as possible. I know when there's different times of stress or with everything going on, we have the ability to let our mind wander. And I'm going to challenge you all for the next 53 minutes to try to stay as focused and present in this webinar as possible. So what are we going to cover today? Like Dr. Murphy mentioned, this is the second topic. So last month, I focused a lot about language and the importance of language. And if you attended that presentation, thank you for coming back. If you did not and you want to learn more about that, Dr. Murphy or Kathy will probably add and post a link to where you can find that video in the chat. But what you're going to see here and throughout this entire presentation is the words sexual and affectional use interchangeably. So for instance, we're going to begin with distinguishing between sexual, affectional, and gender identity. And for the rest of this presentation, I am just going to use the word affectional. And I'll get into why I think that word is a more promising word and a newer word that's being used. But I have the term sexual in here because it is a more familiar word. We're going to talk about the importance of the minority stress model when working with individuals of an affectional identity. We'll discuss and increase mental health needs, illustrate the reasons for the underutilization of services, and discuss a lot of different factors. Lastly, I will highlight some guidelines for behavioral health care workers when working with sexual, affectional, and diverse individuals. Like I say in any of the webinars that I do, this is really just the beginning of our learning. It really is the beginning of our quest for knowledge in improving services for this population. So thank you for being here, and I hope that this does not end your knowledge quest. So I really need to break out the difference really quickly. Today we're going to be focused on affectional identity and not gender identity. The topic next month actually will be focused on gender identity. So that's where we'll talk all about gender diversity. However, and I wish I would have really thought about this and planned this out a little bit better, because today is actually the International Transgender Day of Visibility. So I feel as though I can't discuss this topic with at least acknowledging that and bringing that to everyone's awareness. So that is today. But when we talk about affectional identity, it really is a different construct from gender identity. And I really like this quote to highlight the differences. Even though the language is a little dated, I think it gives you a better understanding about the difference. And I'm going to tell you, so when I was doing a lot of research on affectional counselors who work specifically with affectional identity or affectional diverse individuals with a serious mental illness, in my research, I was constantly having participants try to talk about transgender individuals and talk about pronouns and bathroom use. And it really made me recognize that we just tend to lump everybody under that umbrella term of LGBTQ+. But this quote, I think, highlights the difference between affectional and gender identity. So it says the difference between gender identity and sexual orientation is the difference between who you are and whom you love. So today, we're focused on whom you love, not who you are. So what are we not talking about today? So I want to throw this out there so that you're not sitting here for the rest of the time thinking, oh, well, when is, Dr. Zazarino going to talk about this or that? So since we are only focused on affectional identity, we will not be talking about pronouns. We're not talking about gender. We won't be getting into gender diversity. We're not talking about transgender. We're not talking about non-binary today. We will be talking about that next month. So April 28th, I believe, is the date of the next webinar, and that'll be the topic when we really delve into this a little bit further. So when we talk about affectional identity, and you could hear I already just caught myself trying to say sexual identity, and that's okay. I think as we become more familiar with the words that we use, I think, and if you hear and if you watch the video that Dr. Murphy just put up, it's okay to mess up from time to time. It is also okay to recognize it and correct yourself verbally. So affectional identity. It's important to look at this from three different aspects because there's a lot that is involved when we're talking about affectional identity and just affectional behavior, right? So we break it down into these three different constructs that it is, a little bit more than just identity, just like we will talk about next month with gender, that we have some sort of affectional attraction and affectional behavior. And that's really different from affectional identity. So here's the definition of affectional identity or affectional variance. And you're going to see, and I'm not spending a lot of time on that because you can see it in the video that was posted from last month, but really changing the view and helping people understand that it is more than just sex, right? That two people are connected in more ways than just sex, and it's not just about sex. And that's why the term sexual identity is, and even sexual orientation is shifting to affectional identity. And it is the direction in which one is predisposed to bond emotionally, physically, sexually, psychologically, and spiritually with another person. It's how we all connect as human beings, right? And it's more than just one construct. It has all of these different aspects involved. And I just put these here just to make sure that we all have some sort of common knowledge base. I'm not getting into them specifically because we don't have the time in an hour and this was already done. But you have these PowerPoint slides just to give you some understanding as well about the definitions of some of these different affectional identities. So we look at gay, lesbian, bisexual, asexual, demisexual, omnisexual, sapiosexual. These are some of the identities when we're talking about affectional identity. When we have a conversation about working with people who are affectionally diverse or affectionally variant, right? We need to recognize and talk about this minority stress model because it comes into play and is really important when working with this population. What this theory does is it proposes a really new way of how to understand the different health disparities experienced by this population. And we're going to get into some of the different things to be aware of and some of the different health disparities. Specifically, though, the minority stress model highlights that stigma associated with minority identity confers additional chronic stress, which then contributes to negative health outcomes. So when we're looking at the minority stress, it really falls along a continuum, right? It falls upon stress that's enacted on somebody, right? So whether somebody is being discriminated against, victimized, or harassed, those are stressors that are enacted on somebody, or internal stigma, right? So feelings of personal rejection, concealment of identity, internalized stigma, all of that the stigma that's enacted and personal stigma really does generate greater negative health outcomes for individuals that experience this minority stress. Not only physical health comes, but also it really leads to worsening psychological health. And that really is important to understand, like, where is this really coming from? Why might somebody be experiencing some of these negative outcomes that we're going to talk about? There's a lot of different issues that we can talk about. And in this limited time, we're going to focus on these 7 factors to consider, right? We'll start talking a little bit about the mental health and mental health services. But in order to talk about that, it's so crucial to highlight these other aspects as well. So we'll talk a little bit about victimization, substance use, suicide, medical issues, and relational issues. And as we go, like Dr. Murphy said, if there's any questions, please feel free to add some comments, questions, and we'll touch on it at the end. Okay, so when we look at mental health and mental health services, we know that there are higher rates of mental health issues which can be directly correlated to victimization, stigma, prejudice, and discrimination that many affectional minorities might experience. So let's start with the first idea, right, of victimization. So victimization may first start during adolescence, and many are susceptible to re-victimization. Unfortunately, the statistics and the numbers of this is not as accurate because a lot of researchers might estimate that about 85% of reports remain undisclosed and unreported. But we know that victimization comes into play in many different facets, whether it's verbal, physical, emotional, or psychological. So stigma and discrimination related to an individual's minority stress may lead to chronic stress and exacerbated mental health problems. So there's a lot of documented research that talks about the experiences of affectional diverse individuals related to discrimination and how living in a heterosexist environment might be a contributing factor that leads to an increased risk in developing mental health diagnoses. So what does that really mean? I give you a really good example of this. One of my really close friends was getting married over the summer, and she has 3 kids of her own, and she was getting married to a woman. And so a couple of her supervisees, so counselors in training, had emailed her, and in every one of their emails, they kept saying, "I hope you and your husband have a great wedding." And it was such a great opportunity to talk about where does that assumption come from? And the assumption generally falls in line with the applying heterosexist views on everybody. And it really is looking at, and we talked about this last time as well in terms of language, right? And being able to recognize that there are differences and using language that might be a little bit more neutral and not as stigmatizing or not as biased as that. There was some conversation and some discussion after that between her and the supervisee, but it really was about bringing more awareness to that conversation. Many individuals become hypervigilant as they begin to anticipate and expect negative reactions from members of the dominant culture. And, you know, I know we're saying this in 2020, and I think for any of us that are living in the Northeast, we might think, you know, this doesn't really happen. But I have to say it happens more than we think, even in more liberal areas. You know, even in New Jersey. I travel all over the state of New Jersey, and I actually just did a a training at a facility down in South Jersey, and there were a lot of people in that training that had some views that were grounded in a lot of stigma, and they voiced those views openly. So we need to recognize that yes, it's better. It's better than it's been over the last decade, but it's still existing. And because of some of those fears, people might expect or anticipate some negative outcomes. There is also the fact that some individuals are still concealing their affectional identity, which really does create some internal conflict, which leads to higher stress and anxiety. And concealment of identity could be many different reasons, right? It might be grounded and rooted in religious reasons. They might be concealing the identity based on some sort of cultural background. And all of that then is a feeling of being oppressed, being unable to express and be who you really are, which increases one's internal stigma and increases that internalized stress. And I actually just saw this working with a 23-year-old woman at the intensive outpatient program that I was working at, who was really struggling with just anxiety and depression. And part of it was because she said that she couldn't be who she wanted to be in front of her family. She comes from a culture where being a lesbian was not, would not be, from her perspective, would not be accepted and okay. And, you know, in that group, we processed all of that. And we processed, okay, well, what would it feel like? What would it, you know, how would it feel for you? And, you know, one of the webinars, we're going to talk about the coming out process as well, because that's a very individualized process for everyone. But for this person, she had decided to not come out to her family because she didn't want to put them through it. And she would rather stay in this dichotomy of who I will present to my family and who I will present to other people. And every week she would come in and I would see, you know, the stress kind of weighing on her. And then eventually, she was also somebody, and we'll talk about this in a little bit, about substance use, really was struggling with substance use and increased her substance use and actually overdosed and is fine now. But a lot of it, when she came back, continued to say, I just couldn't handle not being genuine and authentic in front of people. So this is still happening, and it really does impact people who might have to feel like they are concealing their identity. The other thing associated with mental health needs is the idea of, well, if I can't be who I really am, I don't feel comfortable fitting in. And that could really impact one's social support, right? And not feeling like I have those connections out there. And we all know that social support and building a community of people who support us are really good protective factors. And without those, we'll see higher rates of mental health needs. So over time, many individuals can experience feelings of shame and guilt, leading to, like I said, the internalized homophobia. So if we have all of this need, right, we know that individuals that identify as affectionally variant or affectional minorities might have more mental health needs, well, one would think, okay, well, then they'll just receive the services. And unfortunately, that is so far from the truth. Even though there's a greater need of services, this population has an underutilization of services. So beginning with the whole mental health field in general, right? So the American Psychiatric Association finally removed homosexuality as a mental health disorder in 1973. But it wasn't until actually 1986 when homosexuality was fully removed as a diagnosable mental illness in the DSM third edition. And the World Health Organization did not delist homosexuality until 1990. which prolonged the experience of stigma and prejudice for many. So there's already this uneasiness of individuals to receive services from a profession that really pathologize their identity. So we're already starting behind the 8 ball there. The other thing that a lot of the research talks about is regarding competence. So counselors working in the field, yes, they receive some training in multiculturalism, but for many counselors, and I'll just speak for myself and then the people I know for right now, in a 60-credit master's program, you might spend a week, right? A week on working with individuals of the LGBTQ+ population. And for many of us, we're not getting that knowledge. We're not getting the education. And this is why there's so many, it's so important to go out and seek all of that knowledge. So when counselors are individuals are going to seek services, they might be seeking services from people that might not be as competent as they should. And we already know that if the fit isn't there, right, if people don't feel comfortable in the environment, they might not go back anyway. So if they're not feeling comfortable, well, then they might not go back again. And a part of that is really related to a competence issue. So there's a lot of different facets that come into play, but really we recognize, and this is why I think we're all here, and I'm very proud that we can all be here together to increase our competence and increase our education so that we can continue to provide these effective services. So it's sad to say, but as a population, affectional minorities are disproportionately affected by substance use disorders. They have higher rates of use with marijuana, cocaine, ecstasy, methamphetamine, and even prescription drug use. Recently, there was a survey done in 2015 that looked at specifically lesbian, gay, and bisexual men and women across all age brackets. And they were significantly more likely to have misused prescription pain relievers in the last year compared to heterosexual adults. And they had almost 3 times a greater risk of opioid use disorders compared to heterosexual adults. We know that the opioid epidemic is rampant, and that's why I think the 6th series in this webinar, the 6th webinar in the series is directly and specifically related to opioid use within the LGBTQ population. But why is this the case, right? Why are individuals using more substances? One of it could be directly related to the increased rates of victimization, which can cause trauma, right? So individuals are really trying to self-medicate themselves because I don't feel comfortable going to counseling. I don't feel comfortable going for help. So I feel more comfortable using to kind of numb the pain, right? So that could be one reason why we're seeing higher rates. Another possible cause might be that those feelings of internalized homophobia that I was talking about that might not allow somebody to go out and be more social, and the anxiety about going out and maybe feeling like I could be discriminated against really reduces someone's ability to create a peer group or to create support systems. So sometimes you'll see people maybe turning to other people that do use as a way of, okay, well, let me at least find some sort of common bond or identity. The problem with this, though, that we know is that the increase in substance use also adds an increase in risky sexual behavior. And we'll talk about that a little bit more in depth on the next slide. And increase in substance use is also correlated with increase in suicidal ideation and suicidal attempts. So we start to look at these different factors, and we start to look at the idea that working with affectional minorities is a really multifaceted process, right? It isn't just one thing, and we need to start to look at people from a more holistic standpoint, because the needs are so unique and so individualized. So when we talk about those medical issues related to substance use, one of the things is we talk about, as people use more substances, they have higher rates of risky sexual activity. And we see that there's higher rates of individuals and higher rates of cases of HIV, specifically in the gay male population. It's important to kind of understand, I think, when we're talking about this, right, and we talk about education and knowledge, is having some concrete knowledge and recognizing some of the differences between HIV and AIDS, and recognizing that research and evidence with individuals who have HIV has come so far. So we know that HIV is a virus, and AIDS is the condition the virus may cause. So people with HIV are concerned about two different numbers. And it's important to understand this for a couple reasons, and I'll speak to one of them in a second. So they're concerned about the CD4 and their viral load. So because HIV destroys the immune cells called the CD4 cells, one way healthcare providers diagnose AIDS is to do a count of those cells. So a person without HIV can have anywhere between like 500 to 1200 CD4 cells, but when the cells have dropped to 200, a person with HIV is diagnosed, is considered to have stage 3 HIV. So in 2017, this is where it becomes pretty important to understand these different numbers. When people are on medications for HIV, they can have viral loads that are so low that it becomes undetectable. And in 2017, so just 3 years ago, the CDC supported the science that someone who received antiretroviral therapy and has achieved and maintained an undetectable viral load cannot sexually transmit the virus to others. So that's this whole campaign that the CDC is putting out there about U equals U. Somebody who is undetectable is unable to transmit this virus to others. Other information when working within this population is getting a little bit of an understanding about different medications that people can take. So there's one that's PrEP and the other one is PEP. So PrEP is taken every day before possible exposure. So you might be seeing a lot of commercials about this recently, but PrEP is for people who do not have HIV and have a sex partner with HIV, have sex with people whose HIV is unknown, or share injection drug equipment. PrEP can reduce the risk of getting HIV from sex by more than 90% and from injection drug use by more than 70%. Unfortunately, PrEP does not prevent any other STDs. It is strictly for HIV. And then PEP is taken within 72 hours after possible exposure. So this is when, if somebody believes, maybe increase in substance use, they might have participated in a risky sexual activity. Maybe they think they were exposed. PEP is for people who don't have HIV but may have been exposed during sex, at work through a needle stick, sharing injection drug equipment, or during sexual assault. PEP can prevent HIV infection when taken correctly, but it's not always effective. So they always recommend somebody who thinks they've been exposed, if it's really early, within 72 hours, to contact either their local physician or the local emergency room, and to get started on this PEP medication as quick as possible. The other thing when we talk about substance use is individuals at a greater risk for one of the risk factors of suicide is individuals that are actively using. Really, one of the greatest risk factors is the idea of anybody who has some sort of impulse control disorder. And if we look at the population that we're talking about, we can see that If they have more mental health problems, that goes under the psychiatric problems. The increases in stressors due to maybe the internalized homophobia, impulsivity, substance use, puts individuals in this population at a greater risk. Specifically, when comparing heterosexual males and females with their gay and lesbian counterparts, they found that gay men were 6 times more likely than their heterosexual males to attempt suicide, and that lesbians were 2 times more likely than heterosexual females to attempt. So psychiatric disorders, primarily depression and anxiety, substance use, discrimination, homophobia, violence, and all of this can really lead to increased risk factors. So when we look at and we're talking about suicide and we're talking about risk factors, it's also important to recognize the warning signs, right? And it's a really quick acronym that I've learned and that I've used that I think is really helpful. It's just called ACT on facts, right? So ACT on feelings, actions, changes, threats, and situations. So we know what the risk factors are and we have a heightened awareness, but we act when we start to see or hear or observe all of these different changes. That's really crucial. If we know that individuals within this population have a higher rate of suicidal ideation, we need to be a little bit more vigilant. So what do we do? How do we work with people within this population? One of the best promising strategies that's, I think, being researched more and more in literature is using a positive psychology framework to work with individuals who are affectional variants. So a central tenet of positive psychology really is to recognize the importance of complementary, alternative perspectives of the human experience that depathologize individuals' experiences, beliefs, and actions while helping them focus on their strengths. We're really coming from a strengths perspective. We're really trying to help people that help validate people and help validate their experiences. Positive psychology really can serve as a particularly useful framework in clinical training and practice that recognizes and builds strengths within this population. And I just put 2 examples here. And if you have some time, and if this was longer, we can really get into it, but really looking at the positive subjective experiences, right? Focusing on activities and in-session experiences that actively support, nurture, and celebrate the client's identities. You can, if you look on the positive psychology website, there's some really good examples and handouts for that. The other thing is character strengths in sessions. So focusing on creativity, integrity and vitality, love, citizenship and fairness, gratitude, and spirituality. And I'll show you where that comes from. So within positive psychology, they have these 24 character strengths. And it's an attempt to present a measure of humanistic ideals of virtue in an empirically, rigorously scientific manner. In the same way that the DSM really tries to categorize mental disorders, these 24 character strengths and virtues are used to assess and facilitate the strengths of the people that we're working with. So you can see that these 24 character strengths and virtues are based on these 6 ideas of transcendence, temperance, justice, humanity, courage, and wisdom. And if you think about the ones that I just talked about before, we're looking at some of the concrete ones like fairness, leadership, love, really building strengths within this middle piece of justice and humanity. In my office, I actually have, I blew this up into a pretty big picture, and what I like to do within session is have, and I typically like to work with, individuals from 16, 24, 25, and even a little higher, but that are really struggling with coming to terms with their affectional identity. And we'll just spend a session and have them throw like a dart at one of these, and we can spend a whole session just talking about and building gratitude or hope, and building personal traits and personal strengths within an individual. So just to make sure that we are saving time for some questions, and I've seen some comments in the chat box, and I'll get to them at the end. So guidelines for behavioral health care workers. One of the things is to ask, right? Ask about their sexual or affectional identity, just as you would with any other question about their lives or their identity. And not only ask, but I would say don't assume, right? I saw the comment about the definition that was posted about bisexuality, and Samara, I'm sorry if I just said your name wrong. Thank you for posting in the chat about maybe another one. What's really difficult, I think, when we're working within this population, and I said this in the previous webinar that I did last month, is some of the language is changing, and it's changing so drastically and so quickly. And some of the definitions, I think, you could look up definitions for some of these terms, and it says so many different things, right? What's most important is understanding your client's perspective of the words that they're using. So if the client says, oh, well, I identify as bisexual or pansexual, just asking a quick little follow-up question, okay, well, saying something like, I have a general understanding of what that is and what that means to me, but I would love to know from you, what does that mean for you? And what we'll find is that we won't make assumptions, right? We won't use the wrong language, and we'll get to understand from that individual, what does it truly mean from them? Be comfortable with issues and terminology. Absolutely, you've heard me on this webinar already say a couple times and correct myself. I think what's also helpful is that being humble to recognize that we will not and we cannot know everything. Even myself, I mean, this is one of my biggest areas of research that I'm constantly reading. And, I thank people if they bring additional knowledge and information, because we have to be comfortable with that. We have to be understanding that language is going to change, language evolves, and that we need to evolve and change with it as well. Make your office space welcoming. How do you do that? One of the ways is, and this might seem so simple, but it really can make a difference. We know that the rainbow flag is indicative, and many places use that as a visual to recognize that we are an LGBTQ+ friendly environment. Think about the office that you have. I always think about this when it was June, and I go to all these different places, and June is National Pride Month, and you see all these rainbow flags everywhere. And then July 1st, you see about 15% of those flags out, and about 85% of those flags are down, right? What does it say about acceptance? And that flag could be just that visual representation that somebody can come in and say, okay, this person is aware and they are a little bit more accepting and friendly. Thinking about the pictures that you use, think about the language that you have in your documents or in your forms. How do you make somebody feel more welcome? And a lot of times what people are seeing is forms that are more open-ended. right? Let the client tell me what their identity is instead of trying to fit their identity in a specific box that we might not have every identity listed. So then by only having, say, gay, lesbian, or bisexual, then what about somebody that identifies as pansexual? We're marginalizing and oppressing that identity. So how do you make people feel more welcome? You have some visuals. Maybe it's that rainbow flag, maybe it is a picture or two, maybe it's pamphlets, maybe it's more accepting forms with open-ended questions with a line to allow somebody to then identify for themselves. Use language that does not implicitly assume the client's sexual identity. So if they're talking about somebody that they're dating, make sure if it's an individual who identifies as a man and they're talking about somebody they're dating, don't automatically assume and say, okay, well, what's her name? Or what is it about her that you appreciate? You know, ask them, and it goes back to that language again. So I really encourage you to listen to that other webinar. You know, using more gender neutral language is helpful. Don't assume language, don't assume someone's identity. Beware of our own assumptions. We talk about this all the time when we talk about multiculturalism and becoming culturally competent, but in order to change the way that we act and the way that we behave, we first must change the way that we think and recognize where are these thoughts and where are these actions coming from. What are our assumptions? What are our beliefs? Where do they come from? You know, I haven't discussed implicit bias in this training, but we recognize that some of us all of us do experience some sort of implicit bias because of maybe we were raised or how we were brought up or just the environmental cues. So where do these assumptions come from? How do we acknowledge them? How do we recognize them in order to change them? Develop systems of record keeping that are respectful of all clients and model respect for the client and their identity. We know that many individuals within this population have had negative experiences in the past, maybe going to counseling or getting or receiving support from behavioral health care workers. So for us, just being a model and demonstrating respect of every client might make somebody feel a little bit more welcome to come in and to talk. We know that above and beyond anything else in this field, the rapport that you can build with a client, the trust that you can build with a client, and the ability to make somebody feel safe and secure, it's so much better than these interventions that we talked about, right? So how do we do that at the beginning? So before the Q&A, there is this slide here that talks about the website, like Dr. Murphy mentioned earlier. There is an email here, and I've seen some good stuff in the chat. I'm also adding some resources that you can all take a look at. I think it is, like I said, this is just the beginning of education and knowledge for all of you. I don't think, and for me, I think just like all of us, it's a constant process that we are constantly evolving in. So continue to look at some of these resources, continue to talk to each other, continue to be open with each other, and just be open with the idea of learning more. So I thank you for your time, especially today and everything that is going on. And I will turn it back to Dr. Murphy.
Thank you, Anthony. So this is an opportunity now for folks to ask questions of Dr. Zazarino. If you have a question, feel free to type it in the chat box or using the Q&A function. We have a question that's come in that I'll start with while others are thinking of questions or typing questions. The question is, I I personally just learned about affectional identity, the term affectional identity, for the first time today, but consider myself a very LGBTQP plus friendly professional. Knowing that this may be the case for many, how best can a care manager like myself broach this topic or ask the question directly about one's affectional identity without causing confusion with the changing terminology?
That is such a great comment and question. And I will tell you, I just started to hear about this probably about two and a half months ago. That's why for this PowerPoint, I try to use sexual and then put affectional in parentheses. I think right now, the best way that I've been handling it is at first when I engage in the conversation with new clients, I'll say something like, you know, if the question of sexual identity comes up, I will use the word sexual identity first because it's something that people are more familiar with. And then I add that piece about education and say, so what I would like to tell you is that for the rest of our conversations, I will probably be using the words affectional identity, and this is why. I think it helps people first with that word sexual identity be able to connect to something that they're familiar with, and then it helps them shape their own perception and understanding of that term and how heavily weighted that term is in just sex, right? And then it helps them understand a new term. I think it's just like anything else when we're helping our clients understand something that's different. We sometimes have to help them connect it and ground it in something that they already know and allow them the time and the education to begin to learn that new word. And I also think it's just as a healthcare worker, just correcting ourselves out loud when we're working with clients so they see and they hear that we are also trying to get to be more familiar with this. But that's why even, I think in the initial email that went out, I think I said sexual identity because it wasn't, this term wasn't as highly used and I wasn't even as highly familiar with it. So just like everything else, we just keep learning, we keep growing, and we keep, I think it's important just to continue to stay humble as we learn new words and as we teach new words. A great question.
Thank you, Anthony. I did, and you may have mentioned this, and I apologize. I lost a little bit of audio for a very brief time, but so we did have the comment from Samara earlier about the definition of bisexual, or how people would define that term. And I think it speaks to the same kind of thing that the participant who asked the question was getting at here. But it is, you know, how do we use terms and broach terms in a way that is least likely to be offensive to someone? Because it does seem that, you know, that there aren't necessarily universally accepted definitions for some of these terms.
So I will say in the webinar from last month, there are some terms that we should absolutely never use, right? And those are listed in there. I always think it comes down to, and I think this was probably the last slide of the last webinar as well. It's about, after we have a conversation, asking that important follow-up question. What does that mean to you? Help me understand, what does that term, you identify, or you said that you identify as bisexual. What does that mean for you? So it doesn't necessarily then even matter what I, in my own mind, think of what that word means, versus I need to know from my client's perspective, what is their perception of the word? What is their perception or their definition? And whether it's the same or different from what I think, that doesn't matter, right? What matters is, okay, well, now I'm going with their language, I'm going with their word, and I'm going with their definition. And by default, then I am validating and I'm coming from their from their perception of it. So I always ask that follow-up question to say, okay, and I think that's what we do with so many other things when clients or people that we work with talk about. We ask them, well, what does that mean to you? How do you define that? To get at a deeper, I think, to get at the deeper level of what these terms mean.
Yeah, I think you're right. I think we do it. We do it when people say a lot of other things, but somehow we either think we don't need to ask, or perhaps we're uncomfortable asking in these situations. So,
well, I always think of when somebody comes in and says, you know, I'm feeling really anxious. Okay, like that's a really loaded word, right? Anxious and anxiety can be looked at and viewed from so many different perspectives. So I have my own idea of what anxiety is, but that idea doesn't matter. So then you ask, okay, well, what is that? What does feeling anxious mean to you? What does that look like for you? So you begin to understand their definition of anxiety for them personally. And I think that's exactly what we need to do related to any of these terms or any of these issues.
Absolutely. Okay, well, I am not seeing any other questions coming in right at this moment. So with that, we'll wrap up here. I'll let you know, my colleague Katya Rivera did post a link to our very brief survey. You'll also receive this link via email after the conclusion of the webinar. I'm just seeing a question come in real quick. Is there a way we can have a copy of the slide that showed the positive 24 positive qualities? So we will be sending out a copy of the slides with that slide included. There'll also be a recording of this webinar posted on our website. And you'll also all be receiving certificates of attendance. So those things will be coming to you over the next day or so. So look for those. If you don't receive it, I'd say by Thursday or Friday, you can reach out to us and check in to make sure there wasn't an error with your email address. So that being said, I want to thank all of you who attended. As Dr. Zazzarino said, we know this is a busy and uncertain time, so we appreciate you taking the time. And most of all, I want to say thank you to Dr. Zazzarino for the information, and we look forward to the third webinar in this series later this month, I believe. Oh, we're not in April yet. Next month. I'm a day ahead. So thank you again. We'll look forward to that, and we'll also send that registration link out to everyone who was on this webinar. And we wish you good health, be well, and we will hope to see you in a few weeks. Thanks to all.
Awesome. Thank you all.